you go. All right. Okay, everybody. So it's 7:05 a.m. in Chicago, right? 3 o'clock in Israel. Thanks everybody for showing up and attending uh, the latest of our regular Grand Round lectures. It's a great pleasure to introduce Dr. David Hampton to the group, who's an associate professor within the Department of Surgery at the University of Chicago. A little bit about David before he gets going, and he's already told me that he has to leave it in about 40 minutes, but we're gonna be fine and on time. So he's originally from Bellevue in Washington State, out in the northwest of the United States. Um, he went to this unknown institution called the Massachusetts Institute of Technology. So he's a rocket scientist from MIT. Then he went to Washington University School of Medicine in St. Louis in Missouri. Um, then served in the United States Navy. So we thank you for your service. And then did his residency back in the Northwest in Oregon State. Then he did his fellowship at Shock Trauma in Baltimore, in Maryland, one of the real major centers of trauma care in the United States. And then continued to be in the U.S. Navy Reserves, and now is in the University of Chicago. So his his research interests include trauma resuscitation, military medicine, surgical innovation, and global surgery. And he's taught really throughout the world trauma surgery, Europe, Asia, Australia, and North America. He's on various editorial boards, and he's also at the University of Chicago, the associate program director for their trauma and critical care fellowship, and he is also the program director at their of their pediatric critical care fellowship program. And today he's going to talk to us on, I think, a very important topic that really is important not just for surgeons but for physicians in general. Well, talking about, I guess, psychological burnout and how that affects things like compassion and how it leads to the loss of compassion and compassion fatigue. So I invite Dr. Hampton to talk to us on compassion fatigue. How do we build resilience? And over to David. Thank you.
All right. No, thanks, Dr. Goodman. Everyone can hear me okay?
Perfectly.
Awesome. Yeah, no, this is a great opportunity. And when I got the email, it's like I would love to participate in this. So again, thank you for the invitation to speak. This was a project that I started shortly after we got here, meaning that the trauma center was set up, and it was myself and a few nurses, and it has since blossomed from there. To start off, I have no financial disclosures, but hopefully in a few years that will change. But this is the University of Chicago, and the University of Chicago sits on the south side of the city. And you can see in the distance there the iconic skyline. And of course, on the right-hand side is Lake Michigan. Well, unfortunately, Chicago is also known for trauma. And this was an early Sentinel paper by Dr. Crandall, which showed trauma deserts. And each one of these circles or radii represents about a 5 mile radius. And you can see where there's some overlap between where gunshot wound/mortality occurs and where there's not. And prior to us starting our trauma center, we were actually in that area where one did not exist. And of course, that brought a lot of angst, and the community decided to protest, and rightly so. And after many demonstrations and several Sentinel events, our trauma center began. The bad part about this is that Chicago's hyper segregated. The north is very affluent. You always see pictures of the skyline, the river, the fountains, but nobody ever goes south. There's a higher level of crime, there's a lower life expectancy rate, and the South is just not a tourist destination. And between the two, there is a rift in the city. And when you cone down on this is some data that we put together shortly after we started, that the majority of Caucasians live in the North, while the majority of African Americans and Mexican Americans live in the South. And here is an example of Chicago, and this is a publicly available website that I pulled this from. And each one of the dots represents a homicide within the city. And you can see that they're pretty much centered around the south, and that's the University of Chicago's shield. And I tried to represent our 5 mile catchment area. So our center is actually serving a area and population that was grossly unserved for many decades. So it's exquisitely unfortunate. But when you take, what I call like the 30,000 foot view, and here's a, picture of the United States from Google Maps, looking at the news, it is bleak. And every day, every morning, you see multiple stories about GSWs. And like I was telling Dr. Goodman, I was on call last night, and we had 4 GSW patients come in and one 7-year-old that was a traumatic arrest. And for all intents and purposes, I think this article from the Wall Street Journal put it very well as Chicago news is nothing but crime. And to a certain extent, it truly is. And to cone down on, our talk in general, the intensity of this is what we're getting at. And when you look at large cities around the world, but you look at those with high levels of murder, mortality, gunshot wounds, etc., you can see by this bar graph or histogram, the majority of them are actually in Mexico. And the bars are small compared to the larger ones at Cape Town and Johannesburg, but when you look at population density, that's what makes these smaller cities have such a higher number across the board. Chicago falls somewhere in the middle. And this is a view of Chicago looking from the north side down to the south side. And I was on call for trauma, pediatric trauma, about a year and a half ago. And this is a example of our pediatric trauma bay. And per usual, 15-year-old young male shot in the right knee. His vasculature was intact, bones were fine, nothing life-threatening, and he was discharged. This is a Google map of our campus, and here you can see where Comer Children's Hospital is, and this is where our adult hospital is located, right across the street. From an outside view, this is what our new hospital looks like. Sure enough, on call again about 3 to 4 weeks later, and a traumatic arrest comes in, and the patient's shot 16 times. And, very unfortunate, pronounced almost immediately when he came in. And when we started doing a deeper dive, and we use electronic medical record called Epic. And what I found out when I went through Epic was this patient was actually born at the University of Chicago, had multiple ED visits with, the pediatricians, et cetera, and then ultimately died at the University of Chicago. And looking at his more recent records, we found out that this was the kid that was over in Comer, had a birthday, and now qualified to be on the adult side. And once I relayed this to the adult teams, the pediatric team, that's where the compassion fatigue, discussion really begins, because this is what we call secondary traumatic stress. So, strong negative emotions experienced by healthcare professionals as a result of treating patients either during traumatic events or around traumatic events. And this is not an uncommon situation. And I'm sure everyone on this Zoom call has experienced this or seen this, where the intensity, kind of going back to that graph, become providers become hypervigilant or irritable, you're exhausted and you have sleep disorders. So all the psychological and physical manifestations. In Chicago, because of our seasons, right now we're in the winter season and it's about -1 degrees outside. We also have the seasonality of trauma, where our higher volumes are usually March through October, where we have more penetrating than blunt, and then you can imagine with ice on the roads, et cetera, that slowly pivots in the wintertime and then goes back. And there's a certain circle of when a patient comes in, we treat them appropriately. They go to the operating room if they have to, or non-operative management. You begin to speak with the patients. We always have a chaplain or a religious provider come in and work with the families. And then, of course, they remain on the ward. And you can imagine when you're on call, you repeat this over and over and over again through a night. And I remember during one night in July, I had a 12-hour shift We had over 30 activations, four traumatic arrests, and thankfully only one operative case. But you can imagine with 30 activations over 12 hours, you're getting an activation about every 20 minutes or so. So it's a pretty busy night. And this is where, begins to weigh on you. One, you start to see the same patients over again, kind of similar to the young gentleman that came in. You get frustrated with hospital logistics. So, that's not isolated to a single institution. There's also family stressors that everyone's dealing with, both personal and the families that you interact with. There's interpersonal conflicts, constantly dealing with consultants. And of course, it's just a perpetual struggle. And this ultimately leads to physician burnout, where you get a state of just gross physical and emotional exhaustion that involves just a sense of reduced accomplishment, even if you are able to do something. And almost to the point where, this extremes, you get a loss of personal identity as a consequence of all these external and internal stressors. Similarly, when you look at why we all went into medicine, right? We were altruistic, you're going to change the world, you're going to do all the fun things in life. And sure enough, you go through med school, residency, and the jaded sense begins, and during fellowship, how much can you do? You get to your first job and you're kind of at that point of exhaustion, having gone through probably close to a decade of training to get to where you are. And this leads to a decrease of compassion satisfaction, where the amount that you're actually putting in, as in that altruistic quality, feelings of self-appreciation are resulting from caring from others, goes down. And this has an inverse relationship with compassion fatigue. The constellation of all three of these is what we call compassion fatigue. It's basically secondary traumatic stress, burnout, and compassion satisfaction, which leads to this. But in reality, kind of going back to my mentors, the question of like, who cares? Why is this such a big thing? And you can imagine back in the days, and like I read and watch the History Channel all the time, and you can see historical um, hieroglyphs of here they're actually doing hernia repairs. I don't know what kind of analgesia they're getting, but they're getting something. And here's one of the papyruses that documents traumatic events and how to treat them. And of course, the various military conflicts unto themselves. The people went through this, and no one ever really talked about it, or they just thought people were off, or they called it shell shocked and whatnot. And these are, for all intents and purposes, individuals in our practice, we call them the dinosaurs. They always start off a sentence with back in my day, or when I was your age, or it's a sign of weakness. And those are conversation terminators. It really doesn't bring the opportunity to discuss those inner feelings and discuss the psychological events that you're having. And thankfully, a lot of these dinosaurs are kind of going away, which is great. And it's bringing up an entirely new breed of surgeons and medical providers. And when you look at the literature for burnout and how we approach our patients, there are a lot of medical errors related to physicians and nurses who have experienced burnout. And when you look at the odds ratio for depression, et cetera, it's actually much higher than what people originally thought. And when you look at the physician burnout in general, looking at this paper, it leads to decreased patient satisfaction, longer recovery for our patients, because you just aren't providing the care that you had thought you were expecting to provide. And similarly, burnout leads to patient safety, and it goes in a vicious cycle. And of course, patient safety leads to your own emotional exhaustion and potentially like patient mortality. And across the board, the stress level is exquisitely high. Looking globally, the world experienced this as well, and everyone was a part of the COVID-19 pandemic. And, when I was in the ICU, I had this on one of our television screens, and I said, okay, we got to make sure that we're doing everything correct. And, this is a snapshot of the world. And Johns Hopkins did an excellent job of chronicling the number of cases by country, as well as having predictive models. And their models were pretty close. But, the one thing that those pictures or those graphs didn't show were pictures like this that a lot of people experienced. And I think this was one of the sentinel events which really brought this topic forward. And of course, all the articles start coming out on who was experiencing what. And to start off, nurses, the bedside attendees, were experiencing higher levels of emotional exhaustion. You always trust the bedside nurse, and you can see where there was a dip in the physicians who were experiencing the same sort of emotional exhaustion. And then, of course, the climate that they were in. The nurses, for all intents and purposes, took the brunt of this, especially at our institution where we have multiple ICUs on several floors. However, there was a pivot, and trauma and acute care surgeons started taking the intensivist leads. And that's where it began to change, where surgeons, medical, surgical intensivists started to experience burnout as well, or compassion fatigue. And people started thinking about, well, what kind of modifiable factors are there out there? And the first thing they had to figure out was how many people are experiencing it. And sure enough, in this poll of trauma surgeons across the United States, 61 of them, or 61%, I'm sorry, had experienced burnout at some time in that last year, whether they reported it or not. They definitely were experiencing the symptoms. And the issue is, well, how do you address this? How do you start to mitigate this problem? And they said, oh, okay, we're going to start doing things for our population, and a lot of them were in university practices, various age groups across the board, but there was a definite hot spot where this was more related to women than to men. And a lot of it was thought to, aside from, their daytime job or nighttime job, depending on when you work, but also the familial responsibilities that, in our population here in the United States seem to unfortunately fall primarily on women. And I think that's what led to a lot of their burnout symptoms as well. And just to close that out, the psychological effects, as we mentioned, the anxiety, higher levels of depression, substance abuse, of which, I know in my practice, I've actually identified people within the hospital that, thankfully we've, gotten them to the appropriate care, and always the risk of, your own demise. So suicidality is much higher because of this. The bigger part that the hospital looks at, of course, is the financial bottom line. And when they look at how much burnout affects the institution, they realize that, this is a large spread, anywhere from 2.6 to 6.3 billion dollars per year across the United States. So it's not an inconsequential issue and really needs to be addressed. So there are various measures that we can use to determine compassion fatigue, and the ProQual 5 is an instrument that is well validated and has been used in multiple research studies. And it goes through various elements of, how much perceived stress do you have? So, within your life, or do you have a social support network from your family, your friends, significant others? How does your childhood play into this? Were you abused as a child? Did you have any physical or mental health issues, which then progressed on to your adulthood? And then, of course, the issues of how effective are you at coping? Meaning, given everything that you've been through before, what mechanisms have you used and do they work? And then finally, the Toronto Empathy Questionnaire, which looks at your ability for your emotional state, but also to demonstrate an empathic response to either your patients or the situation that you're in. So in Chicago, we decided to look at this during COVID, pre and post, and to see just how affected our ED staff was. And myself and a few of the nurses did a study across multiple subspecialties. So not just the nursing staff, not just the ED staff, but we looked at trauma surgeons, our residents, fellows, nurses, chaplains. And what we found out that, similar to the other studies, that the nurses had a lower compassion satisfaction across the board. MDs were a little bit higher. But what also stood out to us was the secondary traumatic stress was higher in our ED techs. And we think a lot of this had to do with one, age, the second one, just lack of experience in the medical system and learning how to cope. So all in all, it was a positive study. We then took it a little bit further and looked across Chicago, so all 7 trauma centers within Chicago, and namely the trauma surgeons to see what their experience was. And what we found out was that, Chicago's a stressful place. The medians were higher than, the entry level meaning 23, for burnout, secondary traumatic stress, and then, compassion fatigue. So across the board, there was a problem. And that begets how do you become successful again? Meaning, how do you mitigate this? And this is what, I like to call like the ice cream truck model, which I'm not sure in your country, but here we have these ice cream trucks which, go through the cities and little kids run out and they buy ice cream and they get all happy and, they're enjoying the ice cream and then the truck goes away and you finish your ice cream and all giddy and hopefully similar to us, everything gets recycled. But then you kind of go back home. And for kids, you go back to school and you go back to doing fun things and you still fantasize about the ice cream truck and how delicious the ice cream was and how it made you feel. Transferring that to being an adult, even though like ice cream is eaten by kids, for us, we develop sporting events or group dinners, or we just do some things as a group to increase or decrease the stress within the environment that we're in. So JAMA came out with a study that actually looked at reducing burnout in physicians, similar to what I had described. And one was if it was directed by the organization, meaning if your hospital came forward and they organized a large event, how much did it impact, you overall? Meaning, was the intervention successful? And when the organization did it, it actually was pretty successful. So it kind of demonstrated that there was a benefit to having your leadership take care of that. When the physicians tried it unto themselves, it wasn't as successful, but it did work, meaning that an intervention is better than no intervention at all. Basically, who does it? But for us, it's the environment. And, I like to call these people the children. It's a picture of my partners up here. And we did a little test, with our nurses, especially in the ED, on trying various interventions that they could actually do for themselves, meaning meditation, deep breathing, going through what we call the 5 senses and identifying things that your senses pick up, breathing exercises, or just progressive relaxation. And which ones did they choose and which ones served a benefit? And what we found was that a lot of people chose meditation, breathing, progressive muscle relaxation. And I think more so because when they do these activities, that removes them from the environment and that puts them in a quieter spot where they can find a sense of calm. Here's my fellow who said he was stressing out. So I said, here, you can use my push-up bars, do some push-ups, you'll be fine. And he totally was after that. A few times we went up as a group. These are our nurses and one of our helicopters behind us. And we're like, let's take a group picture together. And then, this is an example of one day my wife came and she brought food during one of the sporting events that was happening. And all in all, what we were trying to do with these interventions was to decrease that secondary traumatic stress, in some way changing the environment, making it more hospitable for people to work at the highest level. And that's where you begin to build your resilience. And that's exquisitely important. This is an example of one of our trauma bays. You can see all the cubbies off to the sides that have our equipment, anesthesia, stuff in the background, vents, etc. And here at the University of Chicago, we get about 6,500 activations, of which 30 to 35% are penetrating. The ED thoracotomy was exquisitely common and still is here. And the bad part is we have a very homogeneous patient population, serving the South Side, which, as I've mentioned before, is predominantly African American, Mexican American, and people of color. And one thing that we always do, as you can see in that upper left-hand side, is a quick, team meeting before the patient arrives. And then off on the right-hand side, you can see the patient arrives. The ladies in red are UCAN nurses, and they do amazing things with getting our patients to us, and then we proceed to help out. The other things that we do to help change our environment is we are a Army Trauma Training Center. So, going back to those altruistic qualities, like what can we do to help our community? Here's an example of one of my fellows teaching our advanced practice providers how to put in central lines. And here's a nurse practitioner teaching one of our medical students how to do a radial art line. So all in all, we try and bring people into the fold as much as we can to demonstrate that, this is one team and it's one fight. So this is a picture of Chicago in the snow. And one of the bad parts is, we're on call during Christmas, and I changed a lot of the monitors to have a little fire going on to just kind of lower the stress level. That kind of worked, or at least I thought it did, for the holiday season. Our nurses, God bless them, they've created these boards once a month, and each one of us is represented as a different character. And, this was an example of myself, and sure enough, they always include my dog on the board as well. But, the big thing is, kind of looking at that in totality, it's team. The team makes or breaks it, or at least you work as a team through the environment, and you can't really change the patients that come in, but you can change the environment for which they arrive. And that's where the levers that, I put here of compassion, fatigue, and the team sits in the middle. And if done appropriately, as your resilience increases, that lever lifts up. So you have a higher level of compassion satisfaction and a lower level of burnout and secondary traumatic stress. And this doesn't happen overnight. It takes weeks to months to years of fighting through to get to that level where everyone is working at the optimal pace. And in conclusion, this is a selfie that we took, as our team on our helicopter pad with, Selwyn Rogers, who's our department chief, sitting there in the background. So thank you very much for your time, and happy to answer any questions that you may have.
Fantastic, Dave. Very interesting.
Yeah.
Thank you. Anybody got any questions? I mean, it'll be interesting to see how the Chicago experience compares to the Israeli experience, the
Hmm.
Galil experience, right? COVID,
Yeah.
October 7th. So anybody could comment on how the various hospitals in the north of Israel have grappled with this problem?
Yeah,
Dr.
it wasn't a
Hampton,
side. Yes, go for it.
my name is Uri Neiman. I'm the Chief of Trauma at the Galilee Medical Center. Thank you very much.
Mm.
I'm watching from afar, and I know a little of your trauma center, and I've heard through colleagues about it. I believe we have some similarities up north in the Galilee, although it's not completely similar. But we also have a very distinct population, a homogeneous population, which suffers mostly from trauma,
Hmm.
which is the Arab population in Arab villages who make the vast majority of our trauma patients, and definitely of our penetrating trauma patients. And there are problems there are social determinants for trauma. This is no news, but it's very difficult to have cooperation, and sometimes between institutional and institutions and the population which suffers from trauma. And the population suffers, not only the ones who are injured, but in general. And I wonder how do you manage to bridge this gap, sometimes insecurity,
Right.
lack of trust,
Hmm.
to to make people adjust, to make people believe in you as caregivers?
No, and thank you for sharing. No, that was actually something that we had to deal with right from the onset. And it was because there was a large sense of distrust between Chicago's South Side and the University of Chicago, namely because one, large hospital here, and second part is they didn't start taking trauma until 2018. And I actually got hired on to help start the trauma center. And one of the things that we did was we immediately began community outreach. So we have a hospital department that solely does that, so whether it's a community fair, going to a high school, giving a talk, teaching people about medicine, teaching people preventative health. I actually run a free clinic in the South Side, based in one of the churches solely because of that. And it took years to begin to break down those walls. And what I was telling Selwyn was what we noticed that, as our trauma numbers went up, which is what we expected, our acute care surgery numbers also began to increase. And I think that was an indirect barometer of the win. Because before we started trauma and before we started doing the outreach, our general surgery service was probably close to about 8 to 10 patients on the service at any given time. Now fast forwarding 8 years later, it's closer to 30 to 35. So people are coming here because they're beginning to see the value of the trauma center, what we've invested in it, but also how we turned around and invested into the community.
Can I just follow up on what Uri was saying?
Yeah.
Um, in terms of trust, distrust. Obviously, if the, let's say, the profile of the healthcare team aligns with the profile of the patients, you tend to get better
Right.
outcomes, right? So,
Exactly.
what is the experience with the University of Chicago and with Galilee Medical Center? So I'm asking David and Uri of of,
Mm.
of trying to get a a healthcare team which looks like the patient populations they're serving to get better outcomes.
Right. Yuri, you want to go first or?
Uri.
I actually believe that this is one of the strengths of our hospital
Hmm.
is the diversity of its team. Um,
Mhm.
and the fact that we don't need no diversity officers here. We are diverse. Um, um, this truly is, I believe, a strength for us. Um, Unfortunately, this also, I believe, um, I wouldn't say hurts, but it also influences other communities.
Mhm.
Um, from arriving at the hospital, as you said, there is also a tension between the emergency services and the elective services, and as the hospital is thought of as treating certain communities as tr- and I'm really, I have no idea how to. This is way above both my pay grade and my daily work. But you have also the assumption that this hospital only treats trauma. I'm not sure how you deal with this. I mean, you gave me a very good answer. I think what you
Mhm.
need to do is work hard and get good results, and good things will follow. Um, I think our diversity is actually a strength right now, and I hope it will build also towards improvement in the trust with all communities.
Mhm. No, absolutely agree. I think we're on the other side of the spectrum, as like unfortunately probably see in American news and all that. Diversity is becoming difficult or has been difficult, and now it's a significant hot topic throughout America. And I'm African American, and when you go to a hospital, especially a trauma center, you may see, if you're lucky, one African American surgeon or one African American provider within that academic center. The uniqueness of the University of Chicago is that we have four African American surgeons within one section. And that section primarily is what, reaches out to the community that looks like the African American surgeons. And, some of my partners get a little frustrated, when they walk into a room and they try and talk to a patient, and the patient is exquisitely reserved and, really isn't conversant. And then myself or Ken or Toba or Selwyn walk in, and it's a totally different ballgame. And it's no fault of our own. You can't change who you are or how you look, but you're 100% correct. The level of patient care goes up significantly. The level of reception and willingness to listen goes up leaps and bounds. And, we find ourselves apologizing to our partners, say like, hey, I'm sorry. But, the relation is there. And I think that's how we're winning that game. Yeah, very good question, Elliot.
Any other questions or comments for David before he has to bounce in about 3 or 4 minutes?
Yeah, I can't say, this is a great topic. We're actually writing a book, and of course, my partners say you're going to write the compassion fatigue chapter. So, in time, in about a year or so, you'll see another book from the University of Chicago come out where we're targeting like the military experience, and going back to how do providers who are in more austere environments deal with this. And I recently took a trip to South Africa and Cape Town and spoke with the feeder networks for the University of Cape Town and Stellenbosch, which are their primarily large trauma receiving centers. And their level of burnout is exquisitely high, because a small center that has a surgical patient, they can't get them to where they have to go. And how do they deal with it? Or what do they do to take care of their patient at the same time taking care of themselves? And it's a big problem. So I think, the more we have these forums to discuss it and bring it out to the forefront, I think that will inevitably help us all, kind of solve the problem together.
Great. One very last question. What was it that the University of Chicago opened up this level one trauma center so late in the game in 2018?
Right. So it was an unfortunate event that literally happened about 2 or 3 blocks south of here, so within eyeshot. And it was during a demonstration, a demonstrator, local activist who was 16 years old, so above the cutoff to go to Comer Children's Hospital, was shot. And he had to be taken about 45 minutes north to Northwestern, as opposed to 2 minutes north, which is where we are right now. And unfortunately, he died at Northwestern, in the operating room. And because of that, I think that was, what broke the camel's back, proverbially. And from there forward, we got on the bandwagon, and that's what really pushed the University of Chicago to establish the trauma center.
Right.
Yeah. Very unfortunate event.
Right. Well, sometimes that's what happens, right?
Yeah.
Unfortunately. Great. Well, I know that David has to go.
No worries, sir.
Do we have one last question? I heard something, maybe not. No. But anyway, thank you very, very much, Dave. That really was very interesting, and it's obviously very important. And the a lot of parallels, I guess, between Chicago and the Galilee. So thank you.
Yeah, no, for sure. Thank you, everybody, and good luck. And thank you again, Elliot, and stay in touch.
Okay, very good. Thank you, everybody,
Thank
for
you very
attending.
much.
Have a
Yep.
great
Bye-bye.
weekend. Thanks a lot. Thanks, Dave.
Yep.
Bye-bye.